Initially, it was a very personal issue. I actually have 3 cousins with systemic lupus. So at a very early age, I was exposed to how it affects people. At that stage in my life, I had an inkling and thought, how great would it be if I can make a difference in people's lives this way? Nowadays, we can achieve remission.
Welcome to the Joint Space Podcast, brought to you by the University of Arizona Arthritis Center, one of the first 4 centers of excellence in the University of Arizona College of Medicine, Tucson. The mission of the Arthritis Center is to make a difference in the lives of patients and their families by conducting research ranging from molecules to people, by empowering patients to take charge of their lifestyles, and by educating clinicians and scientists to enable compassionate care and the delivery of novel, effective, and safer therapies. Hello, my name is Tracy Shake, and as Director of Community Outreach and Education in the Arthritis Center, I welcome you to the latest episode of the Joint Space Podcast. In the show, we explore a wide range of health and wellness topics with some of the most respected experts and brilliant minds who share the latest research, clinical care, treatments, and medical innovations to help patients discover new pathways to health and wellness. Today's guest, Dr. Ernest Vina, is a highly respected rheumatologist at the University of Arizona. He serves as an associate professor of medicine and the fellowship program director in the College of Medicine, Tucson. He is also a practicing rheumatologist with Banner University Medicine. Dr. Vina earned his bachelor's degree in psychobiology from UCLA and his medical doctorate from the Chicago Medical School in 2004. He completed his internal medicine residency at Cedars-Sinai Medical Center, where he also completed a health services research fellowship. His rheumatology fellowship was completed at the University of Chicago, and he also earned a master's degree in health studies while in Chicago. He joined the University of Arizona College of Medicine in 2014. Prior to coming to the U of A, Dr. Vina served as an assistant professor at the University of Pittsburgh and as a staff rheumatologist in the Veterans Administration healthcare system. He was the core investigator for the VA's Center for Health Equity, Research, and Promotion. Dr. Vina's research interests include racial disparities, treatment preferences, and quality of care and health services. He is a member of the American College of Rheumatology, the American College of Physicians, the American Medical Association, and the Society for Medical Decision Making. Dr. Vina is board certified in internal medicine and rheumatology. In our conversation, Dr. Vina answers the most pressing questions about rheumatoid arthritis, RA. We are excited to dive in, so without further ado, here's my conversation with Dr. Ernest Vina. So, Dr. Vina, thank you for being with us today. Our episode is titled Q and RA. So this is our opportunity to learn from you answers to the most asked questions about rheumatoid arthritis. So we're going to start somewhat basic and then get into a more detailed discussion. So if you can tell us what rheumatoid arthritis is and what its primary signs and symptoms are.
So thank you for inviting me to be part of this podcast. It's an honor. So rheumatoid arthritis is a chronic systemic autoimmune disease that can affect people of varying races and ethnicities. It affects both men and women. And it is a disease that typically presents with patients having joint pains, joint swelling, and stiffness of the joints. And it is a disease that is treatable. But when untreated, this type of disease can actually cause chronic pain and disability and damage of the joints as well.
So, Dr. Vina, you have a diverse background. And of course, you were an internist first before you became a rheumatologist. What was it that interested you in going into the field of rheumatology?
Initially, it was a very personal issue. I actually have 3 cousins with systemic lupus. And so at a very early age, I was exposed to what this type of disease how it affects people. So at that stage in my life, I had an inkling and thought, how great would it be if I can make a difference in people's lives this way? And when I was a medical student, I was able to do a rotation in a private practice setting with a rheumatologist. And this particular rheumatologist was just beloved by her patients. And to be able to follow patients over time and form long-term relationships with them, I thought was a great perk. And then eventually, as a resident, I was able to be exposed to research in rheumatology. And I thought it was a great way to potentially advance the field. So it's basically one great experience after the other that made me realize this was my calling. I wanted to become a rheumatologist. I wanted to become an investigator and hopefully help patients and help advance the field.
And how fortunate we are to have you at the University of Arizona. So what causes RA? I know there can be multiple causes, but if you can start with what we know to date.
Yeah. The exact cause of rheumatoid arthritis is not completely known, but it's thought to be related to various different factors, including patients' genetics as well as environmental factors. We know that rheumatoid arthritis may run in families, to suggest that there is a genetic component into it. We also know that hormones may also play a factor. This is a disease that is more common in women than in men. Lifestyle factors may also a contributing factor. Smoking and obesity, for example, are risk factors to the development of the disease. And we know that smokers, for example, are less likely to respond to therapies that we give in rheumatoid arthritis. And infections, possibly, and pollutants can also lead to the development of the disease. And what we know is that rheumatoid arthritis is an autoimmune disorder, which means the body's immune system is attacking its own cells and tissues. And this causes inflammation of the joints that can lead to pain and redness and warmth of the joints. And that eventually leads to chronic damage and thickening of the joints, but it can also affect other organ systems, not just the musculoskeletal system.
So since we know that RA can be multifactorial, what other organ systems can be involved?
So we do know that rheumatoid arthritis affects, first of all, multiple different joints of the body. It can affect your hand joints, your elbows, your shoulders, your hips, and your knees, and your neck. But this is a disease that can also affect other organ systems. What's not uncommon in patients with rheumatoid arthritis is this condition called Sjogren's syndrome, which can lead to dryness of their eyes and their mouth. Rheumatoid arthritis can also affect the respiratory system. It can cause thickening of the pleura or the lining of the lungs that can cause chest pains. It can also affect the lung parenchyma that can lead to interstitial lung disease. Rheumatoid arthritis can also affect the heart. If anything, the prevalence of heart disease, such as heart attacks and its complications, such as stroke, is also relatively high in rheumatoid arthritis patients compared to those who do not have rheumatoid arthritis. It can also affect the blood and can cause anemia. So it's not just a joint disease. It can affect multiple different organs of the body.
And how is it diagnosed? What types of lab studies, imaging? If you suspect rheumatoid arthritis, how is that diagnosis made?
So we start by talking to the patients and getting some history and gathering information from the patients on how the disease may manifest itself. And patients typically complain of having pain and swelling of the joints. Then we proceed with doing a physical examination. With the physical examination, we may see or notice tenderness of patients' joints. We may observe swelling of their joints. And in patients who had been untreated for years, they may have deformities as well. Then we proceed and do some blood tests, and we check for their inflammatory markers, which are typically elevated. We also check for specific serologies or autoimmune tests. It's just a rheumatoid factor in this test called the CCP antibody that tends to be positive in patients with rheumatoid arthritis. And in addition, we also may order radiographs or x-rays. And especially later in the disease, we may be able to see deformities that are characteristic of rheumatoid arthritis. We may see some joint space narrowing, or we may see erosions on x-rays. So it's not just one test, but it's multiple different tests that may lead us to the diagnosis of rheumatoid arthritis.
So, Dr. Vina, when you talk about imaging in diagnosing rheumatoid arthritis, can you tell us what you're looking for and how you compare differences between types of arthritis?
So what we know is that patients with rheumatoid arthritis tend to have involvement of their joints that are bilateral and symmetric. In comparison to somebody who has osteoarthritis, in which they may have joint symptoms that may be unilateral or asymmetric. In patients, arthritis of the hands, for example, in patients with rheumatoid arthritis, the joints that are typically affected are their knuckle joints, which what we call the metacarpophalangeal joints, and their PIP joints, which stands for proximal interphalangeal joints. So when we look at the X-ray of the hands, we check if these particular joints are actually affected or not. And while keeping in the background, the back of our mind, that in patients with osteoarthritis, different joints of the fingers and hands are affected instead.
And once you diagnose a patient, what is the next step? Is it straight to medication? And if so, what types of medications are you using currently, and or what do we see as up and coming treatment?
So the first step is about educating the patient about the disease, on what may be the cause of the disease or exacerbating factors. And we also educate the patient and offer the patients potential treatments. And there are various treatments that we may be able to offer. In the short term, it's a matter of controlling patients' pain symptoms, and we may offer them non-steroidal anti-inflammatory drugs, what we call NSAIDs, or we may also offer them steroids such as prednisone or methylprednisolone. And these type of drugs can help control the inflammation and the pain that patients may be suffering from. Then subsequently, we offer them what we call as disease-modifying agents that they can take long-term. Some of the most common medicines that we offer include methotrexate and leflunomide, and those may be enough to quell down patients' symptoms. And if those medicines are still not enough, we may offer them what we call biologic agents. And there are various different types of biologic agents. They're typically injectable types of medicines, or medicines that can be given through their blood. And we've been very fortunate in the last couple of decades in having these types of therapies. We can offer them to patients.
And you spoke about this earlier, the prevalence being greater in women than men. What about different age groups at onset and breakdown by ethnicity, possibly?
Okay. So rheumatoid arthritis is present in anywhere between 1% to 2% of the general population. But what we do know is that women are about 2.5 times more likely to develop the disease in comparison to men. And the disease onset can vary in age, but it's typically diagnosed at the fourth or fifth decade of life. But yes, the prevalence may also vary by race or ethnicity. Interestingly, it is highly prevalent in Native Americans in certain tribes, and some tribes may have 5 to 7 times higher risk of developing the disease. What we also know is that African Americans tend to have a similar rate of disease prevalence in comparison to Caucasians. And it has been shown, though, that Asians and Hispanics may have lower rates of disease prevalence.
And can rheumatoid arthritis develop in a young person?
Yes. Among younger people, they typically have different types of arthritis symptoms. And there is this condition called JIA, or juvenile idiopathic arthritis. And some of these JIA patients eventually develop rheumatoid arthritis. But it may not be so easy to diagnose rheumatoid arthritis at such an early age. And the JIA itself may eventually evolve and turn into rheumatoid arthritis. But there's certainly toddlers or even adolescents who do develop rheumatoid arthritis.
Dr. Vina, in regard to the onset of rheumatoid arthritis, is it insidious or abrupt?
Most commonly, it's an insidious disease, and that's patient typically presents with arthritis symptoms that have lasted weeks to months. However, there's a small minority of patients who may have an acute presentation involving one or several joints. And there are those who may have disease manifestations that will last days or weeks at a time. So there may be a range, but most commonly it is an insidious disease.
So we hear sometimes from patients that are discussing their condition that they are in remission. How is that predicted? How is that achieved?
So nowadays, we can achieve remission. And what that means is that the patient's rheumatoid arthritis is very quiescent. But interestingly, we actually have more information and data on what leads to having a poor prognosis or patients not achieving remission. And research has actually shown us that having a very high disease activity at baseline can lead to poor prognosis. We also know that having these high titer antibodies, like the rheumatoid factor and the CCP antibody I was mentioning earlier, carries a poor prognosis. Patients who have high disability scores at baseline may also lead to worse outcome. And when we do an X-ray, if they actually have certain findings like erosions, we know that they're less likely to have good outcome later on. And there's also certain habits like smoking. We know that those who are smokers are less likely to respond to therapies from rheumatoid arthritis and would have poorer outcomes in comparison to non-smokers.
So what about movement and activity for someone who is diagnosed with rheumatoid arthritis? Is that advised? Are there limitations? What would you tell a patient as far as what movement can do or not do for them?
Absolutely. We highly encourage all patients with rheumatoid arthritis to be as mobile as possible. There's actually been research that has shown that moderate amount of physical activity can be very helpful long-term to patients with this type of disease. It helps strengthen their muscles, it improves their mobility, and they tend to have better outcomes. But I always tell patients to, of course, know their limits and to also not overly strain themselves to the point of causing damage to their joints. And sometimes we may refer them to physical therapy so as to guide them on what exercise can best help them.
And talking about movement activity, hopefully pain-free, but we know that sometimes things do advance. And is there a greater incidence of need for surgical intervention with patients with RA, joint replacement and the like?
So, unfortunately, there are rheumatoid arthritis patients who might not have received early treatment, or those who might have had lapses in treatment for whatever reasons. And unfortunately, one of the outcomes of rheumatoid arthritis is that it can lead to secondary osteoarthritis and damage of the joints. And in these patients, we cannot reverse damage, unfortunately. And what ends up happening is some of these patients may end up requiring a joint replacement surgery, which can help actually with these patients' symptoms and can allow them to have increased mobility. But as I mentioned, in some cases, that may be what would be best for patients.
So we know in discussions we've had previously that this is being seen somewhat as a new era in treatment for rheumatoid arthritis. And being an academic physician, a physician scientist, if you could share with us what is on the horizon from a research standpoint and what you maybe predict for treatments in the upcoming years.
So there are lots of research pathways in rheumatoid arthritis, and there are investigators nationwide looking at how we can further help patients with rheumatoid arthritis. Predicting the disease is one pathway of potentially identifying individuals who may be at risk for developing the disease. Hopefully, in a few years, we can use this whole genome sequencing that could be more affordable and available for everybody. And knowing that patients may be at high risk for developing rheumatoid arthritis, there may also be emphasis on preventing the disease development. Tools are being developed to monitor patients' activities and their movements that may signal early disease. And who knows, maybe vaccinations may be developed in the future that can prevent the development of rheumatoid arthritis. And nowadays, there's also some emphasis on risk stratifying patients and having a personalized approach that perhaps in the future, we can find ways to customize treatment regimens depending on the patient's genetic makeup and their specific disease manifestations. And, maybe there may be a cure for rheumatoid arthritis in the future with the application of new genetic engineering methods or cell-based therapies. And then finally, it's also about participatory decision making. And this is how we treat patients with chronic diseases like rheumatoid arthritis. We make sure that we educate patients about the disease and how to best treat their condition. And perhaps it's also a matter of researching how we can best educate their patients so that they can make the right decisions on choosing certain medications and making the right decisions for their health.
Thank you. And we know that we coming through a pandemic, the only pandemic in our lifetimes, that there has been a somewhat of a shift in healthcare, and physicians are in higher demand and shorter supply. And we know that that is true for rheumatologists as well. We hope that changes in the future, and we know that you are a participant in helping change that by educating future rheumatologists. So as the Rheumatology Fellowship Director, can you talk about what makes an effective rheumatologist and how we bring more medical providers into the rheumatology specialty as time goes on?
Yes. So yes, as a fellowship program director, one of my tasks is to interview residents who may be interested in subspecializing in rheumatology. And we are very fortunate in the last several years that there's actually a lot of interest in rheumatology. of physicians in training wanting to subspecialize in rheumatology. And, we look for various different qualities. We are interested in applicants who are motivated in treating patients with various rheumatologic conditions, including rheumatoid arthritis. We want physicians who are good listeners and who can establish good trust and rapport with their patients. We want physicians who are also very motivated to learn and to improve their knowledge base and be experts in this field. And there's no one specific mold of applicant that we're looking for. We want diversity in people who can treat people of various different backgrounds. So it's a big challenge, but we are up to the task, and we want to increase our workforce and have rheumatologists treat patients, not just in Arizona, but around the nation as well.
So as we wrap up our conversation today, for the listener out there that may be concerned that they have rheumatoid arthritis or a family member and it is yet to be diagnosed, what would be the first step that you would recommend?
I think the first step is probably talking to their primary care providers first, expressing their concerns and their symptoms. And then hopefully their primary care provider can refer them to a rheumatologist who can evaluate the patient, who can interview the patient, and provide some answers. Because there are various different types of arthritis, and there are various different etiologies and reasons why patients may have joint pains. And osteoarthritis, for example, is the most common type of arthritis. We know that. But if the patient turns out to have rheumatoid arthritis, then their treatment regimen would certainly change. And it's about finding the right experts who can conduct the right tests and give them the appropriate diagnosis and offering the appropriate treatment regimen.
Thank you so much, Dr. Vina, for an enlightening conversation about rheumatoid arthritis. We appreciate you being with us today on the Joint Space podcast.
You're very welcome.
Joint Space, where people, ideas, science, action, and curiosity come together. The Joint Space podcast is brought to you by the University of Arizona Arthritis Center. To learn more about the Arthritis Center, please visit arthritis.arizona.edu. We appreciate your interest in this show and our Living Healthy with Arthritis programs. If you enjoyed this episode, please give us a like and subscribe to our podcast on your favorite platform. Joint Space is produced by Greg Gillis with assistance from Luke Brower. Graphics were created by Luke Padway. Our theme music is courtesy of MC Yogi and John Pattern. Thank you for listening. Every step counts toward better joint health.